start sharing my screen with you. So greetings from Srinagar Dental College to all of you. And I start my presentation. I'm sure all of us day in and day out are looking at these radiographs and deciding to go about doing a root canal procedure because the caries has approached the pulp. And though there is not much appreciable apical periodontitis. But can we shift our focus from complete caries removal and in the event of pulp exposure, root canal treatment to minimally invasive biologically based approaches to maintain the vitality of the pulp? Vital pulp therapy, also known as minimally invasive endodontic biologically based therapy, endolite, has been a term. These are the terminologies which have been used to intend to procedures which will protect the vitality of the pulp. Why vital pulp therapy? We want to preserve the pulp for a long term. We want to see that the tooth is functional, immunocompetitive for a long time. And there have been a lot of advances in pulp biology. And we have realized that the pulp is resilient, can heal well, and any low-grade inflammatory response is conducive to healing if we remove the irritant. In cases of irreversible pulpitis, the presence of progenitor cells is also seen, and the advent of modern pharmacological and bioengineering strategies have given us a lot of drug delivery systems, new biomolecules, which we can use to recirculate the pulp. And there is a known article by the Gulabiwala group, which talks about the hazards in a molar endodontic treatment, where the ratio is 7:1. So we can definitely think about vital pulp therapy. There is this correlation between clinical and histological pulp diagnosis, which has been established by Ricochet et al. And they found that in a clinical diagnosis of irreversible disease, 5 of the 32 teeth had a histological diagnosis of reversible pulpal inflammation. So definitely, we should not miss out on treating these teeth and letting them lead with vital pulps. In July 2021, the AE position statement on vital pulp therapy came out with Hirschberg chairing the position statement group. And we all know that we intend to get about minimizing inflammation, infection control, and place biocompatible bioactive materials to initiate tertiary dentinogenesis, which can be transdentinal, indirect, or direct. So what's changed in vital pulp therapy? Procedural definitions remain more or less similar, but the indications for the procedures are changing. The protocols are aligning with recent research and trends in the material sciences. Outcome measures are being defined and they are getting better. So the first section, we see how diagnosis is also changing and the terminologies are changing so that we align them with treatment strategies. Traditionally, we have been using subjective and objective signs and symptoms. We have been doing the pulp sensibility and clinical and radiographic examinations. But the ESC position statement now says that we have, in addition to these, we have to use, that is the patient signs, symptoms, and clinical findings, we have to use the caries depth, which we have to assess radiographically. And we will require a little revision to talk about the initial nature of the irreversible damage in classifying the disease severity. In diagnosing the pulp inflammatory state, we still are not going to use the CBCT, but we are going to look for irreversible damage, whether partial or total, which is characterized by spontaneous radiating pain that lingers after removal of stimulus, and how such teeth also may be vital. The AE diagnostic terminology assigns a vital pulp to either normal reversible pulpitis or symptomatic and asymptomatic irreversible pulpitis. But now we are going to estimate the lesion depth on bite wing radiographs and categorize them into deep carious dentine lesion, where you see a slight radio-opaque dentine between the pulp and the carious lesion on the radiograph, and the extremely deep carious lesion where you do not see any dentine present between the carious lesion and the pulp. So we say that the caries has approached the pulp. So Hashim et al. As well as Walters have given us a newer classification of pulpitis, and we would be using either mild reversible pulpitis, severe reversible, or irreversible pulpitis as the three terminologies. Or better still, Walters has given us initial pulpitis, mild pulpitis, moderate pulpitis, and severe pulpitis. What is to be noted in mild pulpitis is heightened and lengthened reaction to stimuli, and in moderate you have heightened and prolonged reaction which can last for minutes, and this histologically implies that there is extensive local inflammation confined to the crown pulp. Whereas in severe pulpitis, the signs and symptoms are similar to symptomatic irreversible pulpitis. So here now we are aligning the diagnosis with the treatment. So initial and mild pulpitis, you can go about carrying out the indirect pulp therapy. In moderate pulpitis, we can think about partial or complete pulpotomy. And in severe pulpitis, also, if the coronal pulpotomy bleeding can be arrested in 5 to 10 minutes and the root canal orifices can be left intact, and we can also carry out coronal pulpotomy in cases of severe pulpitis if we can control the bleeding. So there has been a paradigm shift according to AAE. Now we should also include as a diagnostic criteria the direct observation of the pulp. So here we can see to it that a misdiagnosed necrotic pulp can also be accurately identified, and observation of the pulp tissue during and after achieving hemostasis will give us additional information about the condition of the pulp tissue, and hence even symptomatic pulps will be candidates for vital pulp therapy. The ICCCC, that is the International Caries Consensus Collaboration, has also talked about changing terminologies, doing caries tissue removal according to them, and managing cavitated carious lesions. So now we are moving to the terminologies used by the ICCC. That is, we have to classify the caries according to soft, leathery, firm, and hard. So based on that, we either do selective caries removal to soft dentine, we either do selective caries removal to firm dentine, and we also do non-selective caries removal to hard dentine, which in deep caries management we are not going to do, and it is no longer recommended. So let's look at the unexposed pulp, where we can carry out indirect pulp management in cases up to moderate pulpitis. So here what we are trying to attempt is we are going to reshift the ecological and metabolic balance of within the biofilm and promote remineralization, arrest carious lesion, and also initiate dentinogenesis. So the European Society Endodontic Position Statement given by Duncan et al. Does talk about the aseptic management, that is tooth disinfection, sterile techniques, use of rubber dam, possibly use of microscopes, and managing deep carious lesions to avoid pulp exposure. We can either carry out a selective one-stage caries removal or a stepwise excavation when the signs and symptoms of reversible pulpitis provide radiographic assessment indicates caries to be no deeper than the pulpal quarter. And one surface occlusal carious lesions have a more predictable outcome than the multi-surface lesions. So as we had already seen, the ICC recommended strategies: selective removal of carious tissues to soft dentine and to firm dentine, stepwise removal, and they no longer recommend the non-selective or the complete removal to hard dentine. We all know that once the bacteria demineralize the dentine, the growth factors are released, and these growth factors and the biomolecules will wake up the sleeping odontoblast, and we'll have reactionary odontogenesis. And lot of growth factors, which can be even produced by recombinant therapy, like the transforming growth factor beta, and other enzymes like heme oxygenase, simvastatin, emdogain, and ODAM have been used to stimulate transdentinal dentinogenesis. In caries research paper in 2020, the terminology of dental caries and dental caries management, there was a consensus report of a workshop organized by ORSA and the caries research group. And the terminologies here also are similar: complete caries removal, incomplete or partial caries removal, and the stepwise caries removal. So the consensus is there in the brackets for you all to see. And partial caries removal got 100% consensus. So they advocated partial caries removal to be excavated till the soft dentine on the pulpal end and on the peripheral walls of the deep cavitated lesions. It is to be excavated to the hard dentine. And this treatment was also termed as script by Clarkson in 2021, right, in this year. And the partial caries removal to soft, and we talked about the firm and leathery dentine. The periphery has to be firm and hard dentine, and the pulpal end has to be soft dentine. The stepwise caries removal propagated by Buonda et al. Right from 1997, and he has been doing a lot of research on the stepwise caries removal. The stepwise caries removal involves removal of the carious dentine, leaving a soft dentine which is very close to the pulp, but the periphery you excavate till the hard caries is till the dentine is hard, and then place a calcium silicate based cement temporized with GIC, and after 6 to 12 months re-enter again, remove the small amount of infected dentine which you had left behind, again place a calcium silicate based cement and do a complete restoration. So this final step of stepwise excavation will give you two advantages. That is, you will be able to assess the tooth's reaction to your medicament, and it will also remove the slowly progressing lesion which has been left behind. Now, what are the variations that I have come across in the literature? One says leave 1 millimeter of dentine and re-enter after 1 year, and the other extreme is leave only residual dentine. Residual dentine, my friends, is the dentine that is just about 0.25 millimeter or so, and whenever you remove the residual dentine, you are going to cause pulp exposure, residual caries. So this was the decision published by my friend Nivedita from Savita Dental College. And let us see how partial caries removal and stepwise caries removal are following after a 3-year follow-up, how they are doing. And the survival rates for partial caries removal are more than 90%, whereas for the stepwise caries removal, it is only 69%. So the results suggest that there is no need to reopen a cavity and perform a second excavation for pulp vitality to be preserved. And a systematic review on the same lines, that is partial caries removal versus stepwise caries removal, also suggests that fewer complications with the partial caries removal one-stage restoration rather than a stepwise. Now, what are the variations? How do we go about in removing this deep carious dentine? We have all known about the strategies. The Schwendike and Innes have given these strategies right from our rotary instrumentations to the non-rotary ones, like using hand excavators or ultrasonics, chemomechanical, where we use Caridex, Carisolve, and lasers, which have been in the vogue now, and photoactivated disinfection. So we have been using rotary burrs and caries detecting dyes, 1% acid red in propylene glycol, and we have been removing the infected dentine and leaving the affected dentine behind. The polyamide burrs are doing well, and they have a Nup hardness of 50, which is closer to that of the soft dentine, and hence they will remove only soft dentine, leave the hard dentine behind. Lasers, Diagnodent will help you to judge whether you have remove the soft dentine and hit on the firm dentine. So here you can see acid red in propylene glycol being used and as a caries detector dye. And but results have shown that if you use anything solely, you're not going to get good results. If you use chemomechanical caries removal, more than 50 micrometer of the caries dentine is left behind. But if you use caries detector dyes, they have 100% specificity. That is, they are going to tell that you have hit sound dentine, but only 70% sensitivity. That is, they will not probably remove all of the residual caries. So Diagnodent, the scores help us to find out whether we are in soft dentine or we have come back to the firm dentine. But even Diagnodent gives us very low sensitivity scores, and so also the caries detector dyes. And there was an improvisation in the caries 26 detector dye, which used a glycol based and was less penetrative, but that also had similar results. Ultrasonic caries removal can be attempted, and it gives a nice clean field, but we hit on to firm dentine much more easily. Lasers and bioactive burrs can be used. Photoactivated disinfection is quite good because it will help us to disinfect the canal with the dye and the release of reactive oxygen. So nascent oxygen. The pulse NDAC laser with some cooling is also good because you cannot increase the pulpal temperature. Odontoblasts will be killed. Even carbon dioxide laser along with black ink has been used to increase the absorption as well as prevention of deeper penetration for indirect pulp capping. Bioburrs are being researched. They have bioactive particles. So as the caries is being removed, so also the infusion of bioactive particles so that we can enhance pulp repair. What are the variables in means to remove the caries? We have seen them. There has been a survey by Covey MM, and they have seen that most clinicians use the burrs and the hand excavators, and the takers for polyamide burrs and ceramic burrs are still not many. Then Murray has shown that at least a thickness of 0.25 millimeter is necessary of the remaining dentines to prevent injury, direct injury to the underlying odontoblast. And caries removal with the smart prep burrs is really very good. The carbon steel or the tungsten carbide burrs, if we use, we are definitely going to do over removal because our tactile sensation is very low. But stainless steel burrs, when they are used, we still have some tactile sensation. So Georgi et al. In 2017 told that if you use polyamide burrs, they take more time to remove. They prevent pulp exposure, which is good, but the bonding to the prepared tooth surface is not very good, and hence they recommend a combination of carbide and polyamide burrs. The materials that we use, we are now using calcium silicate based cements, and these cements, to what thickness can we use them in indirect pulp capping is a question. 1.5 to 3 millimeters. So it's a long variation, and that amounts to a good amount of the dentine being covered with MTA rather than a composite material. The final restorations, previous authors have said that you should do it within 5 days or 10 days, but now the AE recommends that you should do it immediately. And the success of indirect pulp capping is varying for different authors from 73 to 96%. And regardless of the material that you use for indirect pulp capping, probably the case selection and the immediate restoration is important. And of course, calcium hydroxide has to be done away with now. Calcium silicate base have taken a strong foothold for even indirect pulp capping. The A position statement on vital pulp therapy. So use caries detector dye and laser fluorescence, that is Diagnodent, as adjuncts to remove diseased tissue. And they also say that you should focus on complete removal of the infected dentine rather than the fear of causing pulp exposure to improve the chances of pulpal repair. So coming to the summarized statement for indirect pulp capping. So we cannot say which technique is better, the stepwise or the partial caries removal, but most of the papers from USA have been talking about the selective caries removal, one step, and the Scandinavian countries have been talking about the two step, that is the stepwise caries removal. And I think so when you reach the deepest layers, it's better to use a new fresh sterile burr or excavator so as to reduce contamination. And there is a potential limitation also, that is if you do a one-stage procedure, leave behind soft dentine, and if the patient moves on, he is seen by another dentist, you may think that there is caries which has been left behind and there may be another intervention. And whether if we leave infected dentine, will it stimulate obliteration of the root canals, making future endodontics difficult, is a relevant hypothesis, but it has yet to be proven. So people can work on it. Also, after you have placed the calcium silicate based cement, you have to see to it that the peripheral seal is good. That is the peripheral seal concept propagated by Elleman and Magne, so that is hard dentine should be present on the periphery. If you look at a well, the periphery of the well should have hard dentine, and you have to remove only the soft infected dentine and leave the affected dentine, which consists of the transparent, subtransparent zone and the turbid layer, intact. Let's look at pulp exposures. What happens when you have pulp exposures? You have to do either pulp capping, partial pulpotomy, or coronal pulpotomy. Pulp capping is the new entrant here when you have a pulp exposure. We have never been doing that. So a pulp exposure can be either due to caries, it can be an iatrogenic pulp exposure, or it can be a traumatic pulp exposure. I think so you are all familiar with the AE glossary definitions of mechanical pulp exposure, which is on a vital tooth and it is surrounded by sound dentine. A carious pulp exposure, which results because of the bacterial byproducts eating away onto the dentine, and this is surrounded by unsound dentine. So pulp capping involves the treatment of an exposed vital pulp by sealing the pulp wound with calcium hydroxide, but now it is the calcium silicate based cements that are being used. The AE has divided the pulp capping into class 1 and class 2. The class 1 indications for pulp capping are complicated traumatic fracture, where there is superficial exposure of the pulp after an accidental perforation, or small exposures which are less than 1 millimeter in diameter, and preferably they are located in the coronal third of the pulp. The class 2 pulp capping is when the preoperative process of a deep or extremely deep carious lesion, the pulp exposure is judged clinically to be in a bacterial contaminated zone with underlying inflamed pulp. Symptoms may be present but are not indicative of irreversible pulpitis. So for class 2 pulp capping, the caries removal should be done under the operating microscope. An additional enhanced protocol is use of 5.25% sodium hypochlorite, and the hemostasis should be attained within 5 minutes, and the use of a hydraulic calcium silicate based cements. There have been good results in observational studies, and this protocol of using hypochlorite is mandatory. Otherwise, you will get lower survival in class 2 pulp capping. So here's a pulp capping done, calcium silicate based cement and an amalgam restoration. Here is a study by Bogan where they have used direct pulp capping for carious pulp exposure, and the exposures have been wide, 2 to 2.5 millimeters, and they have managed to control the bleeding and place MTA, gray MTA, and place the filling, and at a recall of follow-up has been there, and we have been seeing positive results. Another case in the same publication, but on the proximal side. So I am not here to delve into what type of calcium silicate based cements are good. We all know what MTA is the gold standard, but biodentine has been winning now because of its short setting time with 15 minutes setting time. The bioaggregate and the endosequence root repair material have calcium phosphate additionally. And Asghari has been talking a lot of calcium enriched mixture cement, but the Theracal is not being used, propagated nowadays because of the resin content in it. So what is the ESC position statement? Use a hydraulic calcium silicate or GIC when the pulp is not exposed, but when the pulp is exposed, use a hydraulic calcium silicate based cement only, whether you're doing a pulp capping or a partial pulpotomy or a full pulpotomy. There is a healing cascade for any wound. So you have hemostasis, clot formation, there is an inflammatory response, there is cell recruitment and proliferation, and there is remodeling. In the remodeling, we have a hard tissue bridge formation or a dentine bridge formation. MTA and biodentine have given us fewer tunnel defects than calcium hydroxide, and hence they are used. Lasers can be used because they increase the cell recruitment and proliferation because they are low-level lasers, and the clot should be not very thick. It should be thin when you are doing a direct pulp cap. And of course, a hemostasis is the marker of inflammation. Uncontrolled bleeding means there is severe inflammation. Also, the patient's age matters. So if the patient's age is below 40 and he has occlusal caries exposure, good prognosis. The depth and cavity of the lesion, again, according to the ESC statement, deep caries, extremely deep caries. So class 1 or class 2 pulp capping. Hemostasis and disinfection, important for the class 2 type of direct pulp cap. You have to use a hypochlorite. Some people have used chlorhexidine, but any which ways, we have to use some disinfectant. And a study by Baldissera has shown that there is no effect on the expression of the bioactive glycoproteins that are related to the repair. And the blood clot is also very important. We have seen this in regenerative endodontics also. So the clot has to be there, but we try and keep it thin under a direct pulp cap. NaOCl, that is hypochlorite, 5.25% is used, but people have used even as low as 0.33, 0.5 for 1 to 10 minutes. And its effect on the progenitor cell viability at higher concentrations has to be weighed against its property to disinfect. And we also know that when we use hypochlorite and we place MTA over it, we are going to cause some discoloration of the MTA. There are 3 or 4 systematic reviews on direct pulp capping. Lee have used it for sound teeth. So probably we cannot correlate it with the carious exposures and the class 2 pulp capping. Broaden used them, but they use very young patients and they did not include any pulp diagnosis. Paula did it, but they included even partial pulpotomy. So I think so this one is good. That is the efficacy of direct pulp capping for management of cariously exposed teeth and permanent teeth. Systematic review, meta-analysis showing insignificant difference between MTA and biodentine at 6 months, 1 year, 2 year, and 3 year follow-up. So what's the long-term success of pulp capping going to be? Osteodentine, fibrodentine form, we may have poorer success or more failures because you do not have a tubular dentine. Also, direct pulp cap has, most of the studies have been calcium hydroxide studies, and they have said that the failures occur in the first 5 years of the follow-up. So you have to follow the patients up for at least 5 years. And the seal or the coronal seal or the peripheral seal is important for the longevity of the restoration. There is a systematic review on vital pulp therapy with cariously exposed pulp, and all the 3 types of therapies, vital pulp therapies, have been tried. And at the end of 3 years, they found 72% success for direct pulp capping, 99.4 and 99.3% success for partial pulpotomy and coronal pulpotomy. So case selection and proper treatment protocol is important. So are we looking for a tiramisu pair? So we want a conglomeration, a hybrid, where we can provide all the growth factors, all the essential pH, and a firm seal, and have something which is antibacterial also and anti-inflammatory also over the cap pulp, and then probably we will be able to enjoy more success. Pulpotomies. Emerging evidence suggests that vital pulp therapy procedures like partial or complete pulpotomies are carried out in teeth even with symptoms indicative of irreversible pulpitis. So when pulp capping is contraindicated, probably you can do the next step, that is partial pulpotomy, a carious pulp exposure more than 2 to 2.5 millimeters, a traumatic exposure, which is more than 1 or 2 days, you can do Sweck's partial pulpotomy. But people have found that even after a traumatic exposure, only 2 millimeters of the pulp is inflamed even at the end of 7 days. So probably you could try partial pulpotomy even at the end of 7 days for a fractured crown and an exposed pulp. All of us know what Sweck's pulpotomy is, shallow pulpotomy, partial pulpotomy. So you are amputing 2 to 3 millimeters of the pulp, placing a hydraulic calcium silicate based cement, and doing a restoration. There has been a systematic review on outcome of partial pulpotomy in cariously exposed posterior permanent teeth, and they have found good success, and irrespective of whether the tooth has mature roots or immature roots. So now that fine line that we should do partial pulpotomy to promote apexogenesis, yes, is there. But even for mature teeth, you can still try partial pulpotomy. So when we have to move away from partial pulpotomy and do coronal pulpotomy, you're not able to control the bleeding after amputation of the 2 to 3 millimeters of the pulp, you can switch over to coronal pulpotomy. So here you again have the same parameters. You are doing your caries removal, but here you are going to de-roof the whole pulp chamber, ampute the pulp with a round burr in a reverse motion, hemostasis, disinfection, placing a barrier material and a liner and a restoration. So here's a coronal pulpotomy done, hemorrhage under control, the pulp or canal orifices, you can see no more bleeding, place MTA or a biodentine and restore immediately, and the follow-up radiographs, and you have success. What are the variables in its indications? Nowadays, we are seeing a lot of case reports and observational studies coming up with patients with hyperplastic pulpitis, patients with irreversible pulpitis, pulpotomy being done. And we have an interesting case report by Asgari, which talked about pulpotomy for a mature molar with concurrent hyperplastic pulpitis, internal root resorption, and periradicular periodontitis. So that is the picture from his case. So good results. And if you check on the histological evaluation of teeth with hyperplastic pulpitis caused by trauma or caries or case reports, they have shown that the radicular pulp tissue in the middle and apical thirds of the root canal beneath irregular calcification showed intense fibrosis but was free of inflammatory cells. So you could be doing pulpotomies. Asgari in another paper also said that we could do it even for apical periodontitis, vital pulp therapy. So here is another paper by Abela. It shows that vital teeth with severely inflamed pulp also showing apical periodontitis, and hence we could think about doing a pulpotomy. Pulpal hemorrhage will decide on whether it is a reversible or irreversible conditions. 5 to 10 minutes is the limit that has been given for pulpotomy by Witherspoon. Hypochlorite in pulpotomies, that is the big range. You can see people using 0.5 to 6% hypochlorite. They are comparing it with saline, calcium hydroxide solution, with another variable, that is MTA, calcium hydroxide, even lasers. So hypochlorite is a must. Hypochlorite gives better results than even diode lasers. But in the position statements which have been given by AE or the European Society of Endodontics, nobody has talked about the concentration of calcium hydroxide. So probably after all studies are done, they will come up with another position statement and tell us what is the right concentration of hypochlorite that has to be used. So this is some area of research for all of us. We also know that we have to maintain the cell viability of the progenitor cells. 0.3% preserves the cell viability. So hypochlorite should be used in lower concentration. Probably we can go to concentrations which are given in regenerative endodontics. So up to 3% hypochlorite we should use, and buffered or unbuffered, buffered is preferable. Lasers can be used, and lasers should help in proliferation of the progenitor stem cells. And for irreversible pulpitis pulpotomies, if you use lasers for hemostasis, disinfection and biomodulation, so they will also help, but it should not be for more than 5 seconds, otherwise we'll have calcification. Here is a systematic review by Lee on pulpotomy for carious pulp exposures in permanent teeth. And they say that there is not enough firm evidence with respect to pulpotomy being the preferred intervention. And immediately we have Lars Borndal talking about that you should think about pulpotomy as a more biologically based root canal treatment in response to that article. And we should think about cost effectiveness data of pulpotomy treatments, which are urgently required and to be investigated. What are the follow-ups and failures in pulpotomy? Many studies have used sensibility tests, but they cannot be relied on after you have carried out coronal pulpotomy. So false positive responses, Zanini et al. Have told. There could be early failures, spontaneous pain, inaccurate diagnosis, extensive inflammation. In spite of not being able to control bleeding, if you have done, you will get early failures. Delayed failures will show up as a necrosis, fracture of the tooth restoration, or periapical pathosis. So the ESC position statement also tells that you have to follow up regularly with vital pulp therapy. If any symptoms persist, then you have to be more regular at the follow-up, and thermal and electric pulse sensibility testing should be carried out to monitor pulpal response, noting that teeth with full pulpotomy will be unresponsive. So finally, in conclusion, we should use this Duncan et al.'s ESE position statement, pulp capping class 1 or class 2, and partial pulpotomy and full pulpotomy. When do we do a class 2 pulp cap or pulpotomy? It is indicated after exposure of asymptomatic or reversibly inflamed pulp during carious tissue excavation. For class 2 capping of deep carious lesions, an enhanced protocol of the use of sodium hypochlorite magnification is required and the application of a hydraulic calcium silicate cement. And you should remember that alternatively, full pulpotomy may be successful using an aseptic technique in cases where there is partial irreversible pulpitis in the coronal pulp. However, we need better long-term prospective randomized data in this regard. So I conclude with Sri Aurobindo saying that physical things also have a consciousness within them which feels and responds to care and is sensitive to careless touch and rough handling. So everything that you do it with care. To know or feel that and learn to be careful of them is the great progress of consciousness. Misuse of physical things is a denial of yogic consciousness. So I thank you all for your patient listening, and I'm open to questions. I thank my department team members for helping me out with this presentation, for being patient with me. And I thank once again Sri Balaji Dental College, Dr. Subaya and team for this opportunity. Thank you. Good day.
Thank you, ma'am, for this eye-opening session. We're all more confident now in achieving more predictable treatment outcomes for pulp capping and pulpotomy procedures. I would now like to invite DIPALI SHAH ma'am and Dr. Kavita ma'am to kindly go ahead with the question and answer session of this discussion. Thank you.
Yeah, thank you. Thank you, Dipali. That's a very excellent perceptions about various aspects of pulp capping and even a pulpotomy procedure. You have talked nicely about various strategies about the caries removal, and the AAE and the European guidelines and position statements were very nicely explained. And also, as you told, these vital pulp therapy is nowadays a prospective substitute for a root canal treatment, no, in managing permanent teeth with pulp exposure, even with the irreversible pulpitis also. There are some questions. One question already you have told, they are just asked, how about using a biodentin as a pulp capping agent? Just touched upon that.
Yes. Thank you.
Add some point about it.
Sure. Greetings to all of you, and thank you, Balaji Dental College. I'm humbled to come on this platform with all the stalwarts here, and it was really a fulfilling experience to give a lecture here. And yes, I have been talking to answer the question posed by the audience, from the audience here, Kavita, Dr.
Yeah.
Kavita. It's yes, definitely biodentin has been used. When I talk of calcium silicate, I mean anything which is not even MTA based. So we usually classify our bioceramic materials as MTA based and biosilicates. So biosilicates, we do include biodentin. So we do use biodentin as a pulp capping material.
And you told some studies also having comparable results to the MTA.
Yes,
with the biodentin.
And in fact, the biodentin bridges are supposed to be much thicker as compared to MTA.
Yeah, sure. And can you tell about that phase, that is the fluorescent aided caries excavation procedure? Can you tell something about that?
Yeah, that is when you use diagnodent to remove deep caries. It is called as fluorescence aided caries removal. So as we have seen in the presentation also, studies have been using diagnodent and Carey's indicator dye. So you can use diagnodent because when it will hit upon a reading of around 30 or 40, that means you have come on to firm dentine. But when you are at a higher reading, that means you are still in caries, soft caries.
Yeah, sure. And what about the size of the pulpal exposure that to do with the success or outcome of these treatments? Can you throw some light about that, about the size of the pulpal exposure?
Yeah, sure. I'm sure we all realize that the etiologies for pulp exposures are different. If you have a carious pulp exposure, you have seen in the case report that even in a carious exposure up to 2.5 millimeters, they have used, but nothing as has been set as a protocol right now for the size of the carious exposure. The AE statement says that you do a direct pulp cap when the exposure is up to 1 millimeter. But there have been studies which say that you can use it for a traumatic exposure even up to 4 millimeters. So that is what I want to bring to light, that the consensus statement has come in. We all have a position statement, but all these fine protocols need to be set in, and it's nice that a lot of studies are coming up on vital valve therapy, and soon we will have the exact range of exposure for pulp capping. And if you are done an iatrogenic exposure, I'm sure that even a 2 millimeter iatrogenic exposure under rubber dam and isolation that we are all carrying out, we are definitely going to have success with our calcium silicate based cements.
Yeah, sure. And you told about the permanent restoration, that is more important. So can you tell something about the bonding between these MTA or biodentin with the whatever glass ionomer or a composite we are going to use?
Yeah, that is something which I did not touch upon in this lecture because of time constraints, but this is also very important. When you have placed a biodentine or MTA or any of the calcium silicate based materials, we should know what to place over it and when. So studies have shown that when you use biodentine, the setting time is 15 minutes. So you can immediately seal the restoration. So you can use a resin modified glass ionomer over it. And when there have been studies on micro hardness of the biodentine under a composite, under a glass ionomer, so they have shown that we can use even composites, but you have to use a self-etching primer. That would be better instead of using the whole etchant and rinsing it with water and following a total etch protocol. So it is better that we use a resin modified glass ionomer over biodentine. But with MTA, the results are such that you have to either wait for 45 minutes for the initial set to come in, and then place a self-etching primer and a composite restoration. Though there have been studies by Tsujimoto also, which says that you can even within 10 minutes of the MTA placement, I was a little surprised. They got insignificant results with MTA when composite was placed within 10 minutes, 1 day and 7 days. So they got insignificant results, but I think so it's not very reliable to place composite over an MTA within 10 minutes. So for biodentine,
even in this aspect also some studies are still needed actually.
Yes, we really need to study this aspect, because what is the ideal material to be placed? Either we place a resin modified glass ionomer as a liner and then do the composite, or we wait for the final setting of these cements and then use a self-etching primer. In fact, Dr. Kavita, there have been studies now with the self-adhesive composite, flowable composites also, which you can directly place over biodentine and MTA and then carry out the restoration.
Yeah, that's it. And that is one more something related to it only. What is the latest stand on permanent restoration after pulp capping? Is it to be delayed or done on the same appointment? That's what actually we discussed now.
Yeah, we did discuss. when we want, the AE position statement also tells us now that we have to do an immediate placement. Even if we have done a partial caries removal, you have to place a sound restoration immediately. Previously, when we were doing pulp capping with MTA, we were placing a wet cotton pellet over it and using an IRM. But now, at least even if we have used MTA and placed a cotton pellet over it, we are going to use a material like glass ionomer, which is a sealing restoration. But otherwise, if you're using biodentine, a composite restoration is best because we'll have adequate compressive strength also.
Yeah. And one question about, can we use adrenaline for hemostasis if sodium hypochlorite fails to achieve hemostasis?
I haven't come across any literature saying that we can use adrenaline for hemostasis because adrenaline is now initially we'll use it as a vasoconstrictor and then there'll be followed by vasodilation. So the inflammatory response has not been studied for pulp capping. Yeah, so it's better that we use sodium hypochlorite in the class 2 type of pulp capping procedures because we'll carry out disinfection. Just like lasers, we carry out disinfection. Plus there is, biostimulation.
Yeah, that's good. That's good. There are some studies, they are using now PRF, that's platelet concentrates and all for pulp capping. So what is your view on that? There are some studies and
there are a lot of studies and they are showing very promising results with PRF, even activated PRF. So you are providing the growth factors along with the pulp capping material. So, but I think so we need more studies to confirm the use of PRF, which is such a, readily available from the patient's autologous. So definitely PRF is doing wonders in all fields. So it should do well in pulp capping also.
Yeah, there are so many questions. Since Shubhaya appeared, I think the time is up. Okay, Shubhaya?
I saw a question flashed by Dr. Nivedita also. What about the role of EDTA? Yes, EDTA has been used in pulp capping. There are some studies.
Okay, Shubhaya. Yes,
so you want me to finish?
Yeah, please continue this.
So EDTA has been used and it decreases.
DIPALI, there's no problem. You can go on.
Okay, thank you. EDTA has been used even in pulp capping. It decreases the thickness of the clot. Otherwise, the fibrous nature of the clot, it becomes too thick over the cap material. So if you use EDTA, it does decrease the thickness of the clot. And since EDTA is a chelating agent, probably the collagen fibers will be set free, and again we will have stimulation, growth factors will be released, and definitely you will have better healing.
Yeah, that's correct.
We need confirmatory studies.
Sure.
They are all in vitro studies.
Yeah, there are more of clinical trials in those aspects. Yes. Yeah, that's very nice, very nice. You answered all the questions nicely. As you told, the assessment of the outcome, that of pulp capping or a pulpotomy, there should be some unification of criteria for the clinical as well as the radiographic outcome assessments that should be established so that we can appreciate the results and analyze it better. Yeah, thank you. Over to you, Shubhaya.
Thank you. Thank you. Thanks both of you, Dipali and Kavita.
Thank you.
Dipali, a wonderful lecture. We explained in detail about various aspects of this pulp therapy.
One more,
and I'm sure it's the recent trend that things have changed from any problem in my audio?
No, nothing. Fine. We can hear you.
Yeah. This is one of my favorite topics because we were all taught when you see a caries exposure, immediately go for an RC. Things are changing and changing for our good and patients' good. I think this will become a routine procedure with any dental clinic in the future. So, caries exposure
more economical also. Than going for
since we are on one end of the spectrum using endodontics, the other end we are using regenerative endodontics. So why not, repair endodontics
in between.
pulp therapy?
Yes, fantastic. And I loved your quote on Aurobindo, how much it suits this the direct pulp therapy. And of course, it's also a reflection of Dr. DIPALI. It's the same quote of Aurobindo, and it also suits direct pulp therapy. Very nice. So thanks, Dr. DIPALI. Thank you, Kavita.
Thank you.
Subhaya, thank you, Subhaya, and also the entire organizing team for the wonderful opportunity. It's a nicely executed program. Nice lecture by Abad.
You are a very, very dear friend to me. Thank you.
Sure.